I'm Dustin Telford. I'm joined today by Malanga. We both work for ECRI in the Device Safety Consulting Group. Today, we're going to talk about predictive replacement planning. We're going to talk about what it takes to forecast what devices should be moved in an organization over a longer period than most organizations typically look at as far as the window, and how to do that successfully internally or with the right partners. By show of hands, how many of you have had to defend a capital decision in say the last year? Okay, keep your hands up if this still applies to you, and that is, how many of you felt like you have the data to support it? But there's a gap, and that's what we're here to address. Looks like some of you feel like you were confident in those decisions, but there's still a gap sometimes. And today we're going to talk about those gaps that may occur.
All right, for those of you who may not know ECRI, we are an independent nonprofit organization out of the Philly area. And for more than 50 years, our mission has been to improve patient safety and provide evidence-based guidance related to healthcare technology. We have a disciplined methodology and expertise on what we call predictive replacement planning. So let's jump in. What drives your replacement decisions today? Maybe you use that age rule. You pick a number, 7 years, 10 years, 15 years, and that defines old equipment. Problem is, a ventilator in an ICU working 24/7 is a bit different than a ventilator in an outpatient facility that's only turned on 8 hours a week. Age alone is often not a good enough reason to replace equipment. Or maybe you found yourself using that crisis response, waiting till it's an emergency. Your one and only MRI goes down. Now you have to make a decision, replace or repair, and you got to do it under stress. You'll often end up paying more and suffering through clinical disruption. Or maybe finance calls and says, it's your lucky day. You have $750K available this quarter. Please tell me what you'd like to buy. That's not really a strategy. That's budget management driving clinical decisions. The truth is, replacement needs to be data-driven and strategy-driven. Regardless of which of those three you chose, the result is the same. You end up with reactive replacement decisions with higher costs, higher risk, and lower credibility. There's got to be a better way. CFO and CEO, they want something different. They want defensible, data-driven capital forecasts that they can trust over multiple years. That's what we're going to build today. But let's be clear up front, it can take a lot of work.
Okay, so before we get into the framework, just a kind of a reality check about what we are doing here. None of what we're about to show you is proprietary in any way. It's a framework, right? We do have a deeper level that we can discuss later, but we're going to show you the framework for what we find is the most successful for the people that we work with and the organizations that I've worked with and Barb worked with over our careers. First, the first element that any good organization should have is an accurate inventory. You got to know what you have on the books, right? Whether or not, as we see sometimes, whether or not the supply chain claims they have the asset bookings, or clinical engineering, which is typically, in my experience, has a little bit better inventory. You have to have an accurate inventory to evaluate your entire inventory and what should be replaced. You need to have consistent documentation. Your technicians need to be drivers of this as well, right? So you need to know a little bit about the maintenance history besides just a pass and fail under PMs, say, for example. The more granular the data, probably the better, especially when you're making those decisions about what comes next or what to purchase next. Because you need things like how many hours of use or what the utilization is on the device, not age alone, as Barb had mentioned. And third, your systems have to have I just got to see in my notes here. Third, you have to have an integration between several different parties. That might be an integration between your CMS, your finance systems, your ERP, say, whatever those systems are, or it may be translating that information between spreadsheets. But either way, you need to have some integration between those valuable tools. Now, some, in my experience, again, clinical engineering or HTM departments tend to try and keep all of these things, the better or more mature programs, keep all of these things in one system of truth, usually the CMS. But you're still going to have to reach out to finance and find out what they actually paid, for example, at some point during the process and validate it. So here's our roadmap today. We're going to talk about 3 value propositions for any organization and why you should kind of adopt a framework, right, to successfully plan for the replacement of medical equipment in your organization. The first one is, of course, being a financial steward of the organization. We'll talk a little bit more in depth about all of them. The second one is it's a safety guardian. How many in this room would say that safety is one of your motivators or your team's motivators in HCM? We know that, and if you don't know me, that's where I've come from, right? But the third one is becoming a strategic partner in the organization, not being the reactive department, say, for example, or the reactive advisor when the CFO does come to you and says, we happen to have, and the scenario does come up occasionally, we happen to have $1 million we need to spend this quarter on capital, but what do you recommend? Now, and then we're going to talk about realistic paths forward about how you can do this within your organization. So from cost center to financial steward, it's a change in mindset for some of us, right? You're probably here from your organizations. Hopefully we have people that are growing in their career, have just started off their career, and some, as I see, like some of you have been around a lot. But each of us has to continue to get out of the mindset of being reactive as far as those department costs, or simply saying, yes, we can repair it and continue the life of the equipment. It's better to act as a financial steward in this regard. I will always say, if we save money here, we, the hospital, can treat more patients more effectively, right? And spend that money in other places. So on value proposition 1, I said being a financial steward. You need internal performance data, right? This is the data element that you need for your finances. You need to know what you paid for the equipment at the time, what that the fair market value would be if you were to accept the trade-in agreement, and also what you're going to spend, right, in replacing that equipment. We at ECRI, we add an inflationary rate. We don't know if it's going to change over the years or whatever, but we have seen about 3.1% inflation minus the COVID bubble in the last 10 years for medical equipment. But you'll need financial data, as I've mentioned, and you'll need external benchmarks and safety data. No single organization probably has all of this. You may have some larger organizations, and I do see several large organizations here where you have dedicated professionals that are going out and doing their recall management, say, for example, looking at safety. But at some point in your journey, you're probably going to need an external resource as far as the data, right? What are the benchmarks? We'll get into those a little bit more, but utilization and the clinical impact is another data element. And really what we mean by this is what impact would it be if, again, your one MRI, Bar brought up, goes down? How much revenue is the organization going to lose by not being able to treat patients? How much revenue are you going to spend maybe diverting patients? And that's a financial value that your CFO wants to know. But kind of hit one, please, and we'll get a little bit more information. I got to read these slides to you, but again, what your internal data shows you, right? What your financial data shows you, again, the value of that equipment, well, at least when you purchased it, the projected value of replacing that equipment. If you go to the next slide. And, sorry, this is yours, right?
Yeah,
Okay.
so you want to look at external benchmarks and safety data. How does your equipment stack up against life cycle benchmarks? What does reliability data tell you? Are you capturing safety alerts, recalls, problem reports, cybersecurity vulnerabilities? Are you factoring that all in? Are you tracking market pricing and technology trends? And then the last one, he touched on utilization and clinical impact. You got to take into consideration product procedure volumes, utilization rates, clinical dependencies, and backup equipment availability. All of that goes into determining the patient impact if the device were to go down. Think about it and think about how confident you are about your data quality in each of these 4 buckets. We're going to lay out our comprehensive risk assessment framework based on those kind of 4 areas that we were just talking about. So when we do predictive replacement planning, we consider factors that are grouped into these 4 categories. Condition assessment, that's how the device actually is performing relative to expectations. Safety and regulatory, do you have credible data that tells you about the reliability of the equipment? Supportability, can you keep the device running? And if so, can you do it economically? And then clinical and organizational impact, what happens if it fails? Any robust predictive replacement plan needs to evaluate equipment across these 4 dimensions. So we'll start with a more in-depth look at condition assessment. So that considers the age of equipment compared to an expected life benchmark. This flags equipment that may be on borrowed time, but we know that age alone might not be a great determinant. ECRI has a benchmark for expected life that we use to make this comparison. It's based on our in-house experience, and it's available in biomedical guide membership that we have. You also want to look at physical condition and reliability, and more specifically, how is the device performing to expectations? You probably have a measure of something like mean time between failure, but are you able to determine if declining mean time between failure is normal wear of this device, or is it an indicator of premature failure? Without comparative data, you might be guessing. You also want to gather data on maintenance costs and parts availability. We're going to touch on the safety and regulatory issues in more detail when we talk about value proposition 2, but data to be considered there is listed. You want to look at things like FDA communications and recalls, external problem reports, internal experience with your equipment, regulatory compliance, and certainly cybersecurity. In the supportability category, you ask the question, can I keep this equipment running economically? You have to certainly consider manufacturer support status, end of service. Is the equipment currently at end of service, or do you expect it to be coming up soon? Do you know? You should also consider service availability and costs. Although you probably have a measure of your service costs, do you have a benchmark to compare them to? That can be useful. And last, do you currently have the capability to support the equipment going forward? And finally, a good plan considers clinical and organizational impact. What happens if this equipment fails? You want to consider criticality of that equipment, the normal patient volume, backup equipment availability, and downtime tolerance. And its role related to strategic alignment with organizational goals. This last one needs to be important. You need to factor in things like, is your system going to acquire new systems? Are they building new facilities? All of those things have to be considered when you're making a longer term plan. As well as is your system planning to focus on certain care areas? You know, are you growing certain areas? And if so, you need to plan equipment wise to be able to do that. Each of these 4 categories gets scored, and then for each asset, and then you apply weighting to each of them. That is based on, there's no universal rating. It reflects your mission and your risk tolerance and those organizational plans. For example, a level 1 trauma center maybe weighs clinical impact a little higher than a rural community hospital. So it's not a one size fits all. And then the scoring and weighting gets rolled up into a quantifiable priority ranking for each piece of equipment. That creates your replacement plan. It's not based on age. It's not based on who screamed loud enough. It's based on objective, weighted risk assessment. The methodology, like Dustin said, isn't proprietary. We show you the framework, but gathering credible, standardized data across all 4 of these areas can be challenging. That's where external resources can be valuable.
I'm going to walk you through an illustrated example. This isn't a real case. This is kind of an aggregated example. So rural hospital, 350 beds. And hopefully I'm not reading the slide, but I know this slide pretty well. 350 beds community hospital has a 1.5 MRI. It's about 12 years old. Sees about 28 scans a day on average. You have this data over in the, I think it's the right column. Yes. You have this data. You know about the system. What you may need to know that would probably be better to aggregate or get some aggregated information from another healthcare organization or a group of healthcare organizations are things like, what is the expected life cycle for this 1.5 MR, right? And again, not age, right? Age plays a factor, but as we pointed out, the utilization is about a mile, right? It's not heavy, it's not downtown Baltimore. We need to look at comparative service costs, right? Are your service costs, say, increasing? In this example, I'll tell you the assumption here is that your costs are increasing for service. That set service model that you may have, plus those unexpected downtimes. Problem reports for this model family, what's occurring across the board and the current market value. Last thing, and again, we're not telling you to make these decisions in a box. This is a very important thing that distinguishes planning from a data-driven assessment, although we're talking a lot about data, is to incorporate the needs of the organization, strategic needs over the next several years, and the clinical input, right? What do they need? So on technology, I want to make a point of this and make sure that you forecast, right? What's the current technology out there? You have a 12-year-old system. There's obviously been some level of change, and do your clinicians need that right now, or what will be on the horizon? So in this example, we wanted to bring it up because it actually gives you at least three options. You can extend it as is. You take into account that there's no upfront costs. Your service costs are likely increasing, like I mentioned. And you're going to get about 3 years, maybe, of continued support, right? From a good third party, from your own in-house team, or maybe from the OEM. Option B is something that sometimes a lot of organizations forget, right? And that is, you might be able to conduct an upgrade. You might be able to refresh certain components of an MRI system and extend their life somewhere around 5 to 6 years. That does have an initial upfront cost, but it's a lot less. As you can see on the slides, it's about a third, maybe even a fourth, typically, of what that new replacement, just the device itself, is going to cost you. Parts, technology, the refresh happens to also provide some added functionality to your system that didn't exist, say 12 years ago, and with whatever minor updates you conducted in the past. Now, the full replacement model is something that it's usually an A or B choice, right? That people think of. Full replacement is, say, a $1.9 million investment. You're going to get the most life out of the full replacement. You're likely to get the all the bells and whistles, at least that your clinicians need at the time. Don't overbuy, and it'll be fully supported from a cybersecurity standpoint. Here's the financial breakdown. Option A, if you remember, is extend the life. You're going to see an increase in service costs over the next couple of years because of things like that additional downtime, the wear and tear on that device. Option B comes somewhere in the middle, right, and extends your life. Option C is still that 1.9 upfront cost, if you will. Total, though, what this doesn't show on the slide is that you still have to take into account the service costs across the board, right? What are you actually paying? So that 1.9 becomes about 2.2 over the same 3-year period that you would have extended the life of your as-is device. Next slide, or 2.1. I believe this is mine, right? Okay. Yeah, this. So we wanted to talk about like the accuracy of a 10-year projection. The reason we do a 10-year projection is because it's a rolling opportunity, and you become more of that financial steward to the organization. You become a value center to the CFO instead of a reactive center to say what's being replaced. In years 1 and 2, you better have very high confidence about what should be replaced. What should have been replaced, maybe if you just started this journey, maybe a backlog, but you'll have a priority ranking with about 5, maybe 10% inaccuracy. Some things will change over those first 2 years. But if you don't have that, if you don't have that confidence rating, there's something else missing in your internal data. You don't know about your own systems, their utilization, et cetera. Years 3 to 5, that it's more of a window, 10 to 25% of confidence, or let me say this differently, 90 to 75 or 75 to 90% confidence rating. You're looking at preliminary cost estimates. Remember, you're doing a projection, at least how we would suggest you do it. You say, well, we spent X 10 years ago at 3.1% inflation, or whatever that inflation factor is. A lot of people just simplify it, say 3%, and add that on. So you're doing a preliminary cost estimate, but again, you're not selecting the device, you're selecting the device that needs to be replaced. You're telling the organization with enough lead time that we need to replace, say, in the example of the MR, we need to replace that MR at some point. When we get closer to that decision point where we project that we need to replace it, that's when the clinicians chime in and say, we need these specifications because the technology's there. And beyond 5 years is more direction. Your confidence rate is less because you don't know what technology evolutions are going to be out there. And we've all seen an explosion, David, example, especially in imaging, and happens to be lab as well, in AI. What's coming around the corner is less predictable, but you still know that you need to replace the equipment, right? If the trends stay essentially the same. The reason these are all important is it requires that you have a baseline level of accuracy with your data. That you have a discipline, I would suggest at least quarterly, of reviewing your plans, a discipline that you execute on, of updating your plan, right? It doesn't change because the radiologist, the head radiologist or the head in cardiology calls you out. It changes because something changes with the equipment or the strategic mission of the organization. And you have to have be honest about those 5 to 10 year projections. But these are projections based on what you know today. when you achieve these things, that baseline, that level of data accuracy and your confidence, right? You become a financial steward. Instead of doing that reactive asset management that some organizations still continue to do, you become more of that financial steward from the organization. You have a seat at the table when the CFO trusts that your projections are relatively on the spot, that the CFO doesn't have, say, for example, the radiologist screaming in their ear and doesn't have that clinical advisor or clinical engineering advisor on the other side saying, well, it sounds good, but we can still extend the life of this equipment and replace something else. If I could, I'm going to take just a moment and I'm going to give you an example. One of the projects that I've worked on with ECRI, one of the top 10 items that needed to be replaced in, say, I think it was like 2 or 3, was an EKG treadmill because the organization had not taken into account these 4 major categories and our weighting system. They hadn't taken into account cybersecurity updates and everything. I don't think that organization, prior to us being engaged with them, PT and cardiology, this happened to be cardiology. Cardiology even had a voice. It was more those departments that most of us see, at least, with the megaphone. Wow, that's megaphone. Thanks.
All right, let's talk about our second value proposition, become a safety guardian. So HTM professionals have a moral authority when it comes to equipment safety. You know what equipment is safe and what, is becoming dangerous. But saying this machine is old doesn't really convince risk management or safety committees, quality committees. You need objective, credible safety data. So let's talk about it a little bit more. There are sources of safety data out there. Public sources like the FDA publishes recalls that are searchable and important. The MAUDE database is out there. It contains adverse events reports, and manufacturer safety notices provide alerts. All of these are free and accessible. But here's the challenge. MAUDE database contains over 5 million device reports. And anyone that has searched it knows it's not real easy to successfully analyze those and apply them to your specific equipment inventory. FDA recalls are published individually. How do you track them against 10,000 pieces of equipment in your inventory? This is where commercial databases can become valuable. So ECRI has a problem report database, for example, and it aggregates the reports that come from FDA manufacturers and international sources and our own member hospitals. We use standardized terminology and provide actionable recommendations. We have staff dedicated to analyzing medical device problems and expertise to assess severity and aggregated data across millions of types of equipment. Most facilities, even large ones, can't replicate that on their own. We're not suggesting that you have to use ECRI specifically, but we're saying that credible safety assessments can benefit from comprehensive standardized data, and it's out there. The biggest challenge in replacement planning in the last 5 years, and the biggest change, has been sort of the elevation of cybersecurity. So cybersecurity now drives replacement timing as much as clinical obsolescence. 2 dates matter: end of life and end of service. End of life is when the manufacturer stops selling the equipment. Probably not your immediate problem. End of service or end of support, no more security patches, that can be a problem. Over half of connected medical devices have known critical vulnerabilities, and an average healthcare breach can cost in the millions. End of service equipment is where that risk concentrates. But end of service doesn't necessarily mean replaced immediately. It means conduct a documented risk assessment, and there can be a big difference. Maybe you can move that piece of equipment off the network and isolate it and keep it for another number of years. It has to be kind of analyzed.
Here's another illustrated example. This is more based on a real world example than an aggregate. Organization identified about $4.2 million, I think it was $4.2 million of equipment that was end of support from, again, the operating system or the application version. That critical thing that has now come up more in the last, say, 10 years than it did prior to that, especially for these increasingly larger systems that require some sort of cybersecurity support. With a different lens, instead of $4.2 million, the organization identified that there was only about $1.3 million that needed to be replaced or upgraded. Some of it could be mitigated. A lot of it could be upgraded or mitigated through other mitigation factors on the network side to eliminate or at least reduce the risk to the organization. Some of those other devices in this example, a lot of them were networkable, but they didn't store any medical PHI, and they weren't networked. So they don't pose a risk if they're not going to expose your organization to a data breach or to access as a vector to, say, another, like your API systems or whatever. The point is, instead of being reactive and saying we need to spend $4.2 million, it wound up becoming more strategic and a bet, again, around safety. That 4.2 now becomes about 1.3 of immediate need. And then there's the phased approach of those things that may need to be replaced in the future. You become not only a safety guardian, but to tie it back to the value proposition one, you also become a financial steward for the organization.
So when you achieve these outcomes, you move from reactive maintenance to proactive risk management. You're seeing safety problems before they impact patient care. You speak the language of quality and risk, and you have data to back it up. This requires comprehensive safety intelligence, problem reports, reliability data, failure mode analysis, an understanding of cybersecurity vulnerabilities. You need to systematically track these things and analyze across your entire inventory. Very few organizations can build this comprehensively in-house. Most partner with some kind of external resource that specializes in this data. So now let's talk about becoming a strategic partner.
Value proposition 3 is really the combination of successfully executing on the first value proposition, being a financial steward, and the second, being a safety guardian for your organization. To achieve this, to being a strategic partner means you understand with the organization, if you're an ISO, a multi-vendor organization, or you're in an in-house department, that you understand what the outcomes are and what they look like successfully for your organization to bring in the right amount of revenue to treat the patient population area or under your purview. I would also be remiss to say, instead of being from the standpoint of, can you fix this? You now start to shift because you have a disciplined process. You now start to shift that conversation from, can you fix this, or how long can you keep this alive, to what should we plan for and what should we do next? Oh, is this, sorry. This is me. So most organizations make equipment decisions in one or two of these areas, but maybe not all three. What are your technical capabilities to support the equipment? What are the clinical needs or the clinical strategy, for example, moving forward? What are you, say, for example, treating an aging population in your area? Or a lot of young couples maybe having children. Does this shift what the clinical strategy is for your organization? And of course, the financial reality. No organization that we've worked with has unlimited money, right? You need to plan successfully for what you anticipate as far as replacing. To give another example, this is a regional healthcare system. Again, I happen to have worked a lot in rural healthcare just prior to joining ECRI. A large hospital system acquires 3 rural health system hospitals. The CFO comes to clinical engineering HTM and says, what do we need, right? This equipment appears to have been poorly maintained. It is aging, and it looks like we need to replace a lot of equipment. We've acquired these hospitals, but what do we actually need? Tying in, of course, being a safety guardian and being a financial steward, see it through the lens and ask a different question. Should we replace this equipment? But what needs to be replaced? Ask the CEO, ask the COO, and ask the CFO. How are we going to position these new hospitals within our network? It changes the answer. Instead of assuming that you're replacing the same business model that they may have done under, the answer from the COO's office is primary care will occur at these facilities. Any complex care will start to divert to the main campus. And we hope to provide telemedicine services to our patients at that facility so that specialists can get involved and make that assessment before they're transferred to the main campus. This changes the outlook from the organization standpoint, and it changes the financial impact. Here's in this illustrative example, and we are gonna, I don't know that we mentioned this yet, but we should have. We're gonna give you the actual examples in greater detail. You'll want to pull up your phones near the end of the presentation because you get a QR code down. The highlights are about 4.2 million needed to be invested in these 3 hospitals in the first couple of years. That was about safety. There were some critical replacements that also needed to be made due to failing equipment, or that it was predictably going to fail, and nobody wanted to spend those emergency premiums on it. It enabled about 3.1 million less to spend in that organization because HTM understood that we weren't replacing the same business model. Next slide. So when you achieve an outcome of, again, value proposition of 1, being a financial steward, and being a safety guardian, and then layering on there being a strategic partner within the organization, you've completed your transformation from, say, being a service provider to an advisor or a partner within the organization. This doesn't happen overnight for any organization. We've seen that some larger healthcare systems do this rather successfully if they have the time, they have the capability and capacity within their own organization to employ the right people and to spend the time. You could do this on your own if you're a smaller organization. I can tell you firsthand that it takes a lot more work than you may want to invest if you're a smaller organization. But we, with ECRI, we sometimes get engaged with those folks that are just kind of starting out, either large or small organizations, and we help them get to this journey. So if you do this internally, we estimate that it takes about 12 to 24 months. And typically that's in the larger healthcare organizations to really establish the methodology that you'll decide upon, right? To do the ranking system, the weighting system, to meet with the clinical stakeholders, and to get in that cadence of doing at least quarterly, I would say, quarterly updates on this. If it's partner assisted, you can accelerate quite a bit. Is that yours?
Yes.
Okay, sorry.
Most healthcare organizations, including large ones, partner with external resources. Speed is the primary driver. The first comprehensive assessment plan can be accomplished in 3 to 4 months versus 12 to 24, and doesn't require, quite as much commitment of your own assets. You also get immediate access to aggregated data that could take you years to build internally. So ECRI does this work. We're not obviously the only option. The key is choosing a partner with credible data, healthcare expertise, and transparent methodology, and one that you can know what their track record is. Neither path is wrong.
Yeah, neither path is wrong. You can do it on your own, or you can do it with a partner. What we kind of find is the best middle ground for those that aren't ready to necessarily do it on their own completely is partner with somebody, partner with a credible, as Barb has mentioned, partner with somebody credible that has access to certain data elements or methodology. And then my suggestion is move away from that part. Get the partner that actually is going to help you get to a point where you're doing most of this internally with maybe some data sources from other companies.
So 3 value propositions: financial steward, safety guardian, strategic partner. These are achievable outcomes and with measurable impact. The data challenge is real, but organizations that commit to building the capacity, whether internally or through this partnership, they can see material results.
So there are 3 main important things that you need for this. You need credible data, comprehensive and credible data, a combination of your internal resources and those external benchmarks that you need. You need a systematic methodology. You need to be very disciplined in applying the same process every year. You don't want to vary this in the first couple of years, because clinicians who are weighing in on those decisions will typically say, well, last year I had to do this, this year I have to do that. So that discipline applies across the board. And the last is that stakeholder support. And when I say stakeholder support, I really mean that you're working with the clinicians. Near the beginning and peppered throughout, we both mentioned how important it is to make sure that you are working with the clinical staff that understand their needs and the organizational direction that your organization is taking, whether or not it be with the C-suite or other senior leaders. We don't know in a box necessarily that the organization may be planning a merger or acquisition, or expanding services, or wants to expand services to a different market. Thank you.
So thanks, and we can take some questions. That we do have some things for you to take away up here if you want to, and something sweet. We'll give you $10,000, or at least $10,000. And that's the QR code. You can download the same things we have up here available electronically through that. And we're also around, both of us are here for the rest of the day. So feel free to snag us if you want to have further conversations. Yeah.